Welcome to this presentation, which aims to provide clinicians with a background for understanding of why electronic data is important in the delivery of modern healthcare and how this relates to SNOMED CT. Clinical practice continues to develop at a very rapid rate. Historically, clinicians have used data in a variety of formats to inform the provision of care. There has been a transformation over time from handwritten notes to the electronic formats available today in EHRs. The future direction is moving towards personalized care, which requires access to patient data to support the development of patient treatment plans to deliver real-time care. Let's now consider why the delivery of clinical care has changed over time and has become more reliant on the provision of data. For example, the move to predictive medicine requires clinicians to access published papers and clinical audit data to identify what works and what doesn't. The increase on reliance of data is particularly true for the use of evidence-based medicine, where the gold standard for treatment is identified through the use of randomized control trials. These require accessing data from multiple sources to identify the most successful treatments. As we move to a model of personalized care, which is about identifying optimal treatment for the individual patient, the requirement for data increases and now includes alternative sources of data from genomics, social, and economic sources. With these changes in the delivery of clinical practice, the requirement for data that can be processed automatically has also increased. For the delivery of predictive medicine, a clinician could be expected to review the data with no assistance. However, personalized medicine delivery requires the provision of tools to support the clinician. This is particularly true for complex treatment protocols, where the use of decision support systems is essential to aid clinical care delivery. If we look at clinical care provision today, the central theme throughout is data. Data from patient encounters is recorded by clinicians, which is then used to populate clinical registries and other clinical databases. Through analysis of these sources, medical knowledge is expanding at a greater rate than any time in history. But to make this knowledge available to clinicians, the knowledge is formulated into clinical guidelines and pathways of care that can then be used to inform a clinician's treatment choices. As we move towards a greater reliance on data in clinical care, there are inevitably some challenges. One obvious challenge is the quantity of data required. How do you store all this data and access it in a meaningful way? Clinicians recording data also need support to record it in a way that does not impact their ability to deliver clinical care. Data collected by clinicians is used to satisfy a variety of requirements, from support for local care delivery to population-based analysis. In addition, there are a variety of different clinical systems used across the healthcare sector, which record data in different ways and use different formats. We refer to this as the interoperability challenge. And then, as we move to personalized medicine, there is an increased requirement to provide data in a format that can quickly inform clinicians of treatment options. The key factor in the interoperability challenge relates to a need for computable and standardized vocabularies. In addition, these vocabularies need to be flexible enough to support the use of carefully chosen synonyms. The aim of any clinical data collection activity is to provide the individual clinician with actionable insights to support their choice of treatments. Actionable insights require a focus on three areas: clinical characteristics, meaning the determination of diagnoses, findings, and other clinically significant details with an emphasis on counting. This then allows patient-level prediction of the best treatment available and to assist the clinician in informing the patient about what will happen to them. But the information on the best treatment available comes from an analysis of population health data in a variety of formats. At each of these stages, there is a reliance on sharing of data. But if we want to share data successfully, how do we start? From a SNOMED CT perspective, let's start here with a thought. Consider the blue circle in the middle of the screen as representing this thought. In SNOMED-CT, we call these thoughts concepts. A concept can be any thought about anything in the universe, but since this is SNOMED-CT, it will probably be a thought or concept that has something to do with healthcare. We are going to turn this thought into a SNOMED-CT concept. If you follow along, you can see how SNOMED-CT concepts are formally defined using logical relationships. Before we even think more about this concept, we need a way to distinguish it in the huge sea of all the other concepts. Words are not sufficient because words are different in each language. We need some unique identifier, like a fingerprint that will always be the same and that can only ever be associated with this one concept. This fingerprint is called a code. It is merely a unique number, a number that will always be associated with this concept. A code can never be reused. Every concept has its own code forever. Even if the concept is later inactivated, no other concept can have this code. The code carries no information about the meaning of the concept. It is nothing but a fingerprint used to identify it. And while words are helpful for people, they are ambiguous to a computer that needs to understand the meaning of each concept. So in SNOMED-CT, the formal definition of a concept is defined by its relationships with other concepts. Each concept, represented by the circles here, is related to other concepts by relationships, which are shown by the arrows. Each relationship has a specific relationship type that we call an attribute, which is itself a special kind of concept, whose job it is to connect other concepts together based on their meaning. Attributes, just like other concepts, have a code that is unique to them. For the computer, SNOMED-CT is just a huge universe of concept codes that are related to other concepts by attribute relationships. Once we add the words, you'll be able to understand what the concept in the middle means. Keep in mind that these particular words are only helpful if you speak English. So for this reason, SNOMED-CT allows words in any language. Please be aware that these words are just labels, and it's the relationships that provide the logic or the formal definition. On this slide, we can see that our concept is related to disorder by a relationship called ISA. That means that our concept is a type of disease. We also see that it is related to a concept called lung structure, using an attribute called finding site. And finally, we see that our concept is related to a concept called infectious process, using an attribute called pathological process. The words are necessary for us to understand what the concept definition means, but not for the computer, which defines and maintains the ontology of SNOMED-CT. So now we know that our new concept is a type of disease that is in the lungs and is infectious. And from that we can deduce that it represents any infectious disease of the lungs. By the way, when we refer to lung structure in SNOMED-CT, we are referring to either the entire lungs or any part of either or both lungs. Note that if you live in a country which speaks a language other than English, such as Germany or Argentina, then these formal SNOMED-CT definitions maintained by the computer system are exactly the same, because the codes are the same. However, the words associated with each concept may be different, so that people can understand what the term means in their native language. These concept definitions based on formal description logic are a key difference between SNOMED-CT and other clinical coding systems. SNOMED-CT is not just a set of codes and names. It is a logical structure which, as we will soon see, makes it uniquely capable of performing clinical data analysis. As an illustration of how different words can be used, SNOMED-CT concepts all have a long formal name. In this case, infectious disease of lung disorder, which is called a fully specified name, or FSN. All concepts also have one or more shorter, easier names called synonyms. Examples of the synonyms used for this concept are infectious disease of lung, pulmonary infection, and lung infection. Each language dialect can select one of these synonyms as the preferred term in that dialect. Another example is the concept for myocardial infarction. The term myocardial infarction is the US English preferred term, but the concept has additional synonyms such as heart attack and cardiac infarction. Keep in mind, though, that unlike other code systems, SNOMED CT's concepts are formally defined using their relationships to other concepts, rather than just by these terms. However, new terms can continue to be added to a concept as new accepted ways are developed to refer to the concept's meaning. For example, remember when the 2019 coronavirus disease was renamed to COVID-19, a rapid renaming of the concept was required. These concepts within a database can then build up connections to describe a complete picture of a patient. These links can then be used to simplify the connections to a simple clinical statement. But why is all this important? It's because clinicians and healthcare organizations have very real requirements. If you are a clinician, you need timely access to clinical information at the point of care. You need to have support systems in place that help you make the right clinical decisions, particularly in complex care scenarios. You may also need to identify patient cohorts for frontline treatment or clinical audit purposes. At the hospital level, you may need to access data for reporting and billing purposes, and collect detailed episode data for either long-term reporting or to actively manage patients under clinical care in the hospital. At a population level, it can be very important to identify health trends, which may require active management. It can also be important to identify and manage health risk issues quickly, for example, with infection outbreak control. Information may also be required to actively manage chronic disease patterns through health promotion activities that require the identification of a cohort group and the evaluation of the success rate. But data on its own is not enough. Data needs to be structured through both the use of information models within systems and structured terminology. By making the data structured and retrievable, a clinician can record data once and then reuse it many times, reducing a clinician's workload. A structured health record also provides a clear audit trail of clinical care over time. Risk can be managed through the use of decision support systems, which can reduce clinical errors. Organizations can greatly benefit from real-time data, which allows actionable insights to be realized. This allows organizations to improve the management of their patient populations. A reduction in clinical errors can also provide a huge benefit to organizations as a whole. At the population level, access to reusable data improves the support for evaluating and developing clinical care pathways and treatment protocols. Real-time data access also improves the management of population health through the ability to identify and react quickly to change, and also to quickly evaluate the outcomes of interventions. I hope you now have a better understanding of the motivation for recording structured clinical data electronically. For more information, please visit snomed.org. Thank you for listening.